So we're here with Dr. Sonpavde, one of the leading authors for the CheckMate 901 trial. And we're with GU Oncology now, and we'd love to hear a little bit about the trial and some of the updates and some of the things that went on over AUA this year.
Right, so the CheckMate 901 trial is, of course, a phase 3 trial that has been reported initially at ESMO Congress October 2023, and then it's been published in the New England Journal. So what this trial is a first-line advanced urothelial carcinoma trial comparing cisplatin gemcitabine versus cisplatin gemcitabine plus nivolumab, and was only cisplatin eligible patients. So the co-primary endpoints were overall survival, OS, and progression-free survival, PFS. And suffice it to say that in this report here, we essentially looked at the same data set and highlighted the key points in the trial. There was an improvement in OS and PFS. The OS hazard ratio was 0.78, the PFS hazard ratio was 0.72, and also other secondary endpoints improved, including overall objective response rate, which improved from around 43 to around 57%. But really the key highlight take-home message from this trial is the complete response rate. The complete response rate with gemcitabine, which was approximately double cisplatin. And the major highlight of those complete responses is it was highly durable. So the median duration of complete response with gemcis-nivo was around 3 years, whereas with the gemcis alone, it was around 1 year. So that really highlights that the durability and the quality of the complete response is really impressive with this regimen. This suggests that we might even potentially be curing some of these patients. We need more follow-up to be sure about that. But we know historically that cisplatin gemcitabine and cisplatin-based combination in general can cure some patients, especially the patients with lymph node-only disease. So really, that's a key thing to highlight. And the other thing to highlight is that the gemcis was given up to a total of 6 cycles, and nivolumab up to 2 years, and then it stopped. So that suggests that some of these CR patients got a treatment-free interval. Yeah. So they completed treatment, and they were still in a complete remission. So that's a really important fact.
If we took a step back and looked at things before this trial, right, before we would add nivo, what are we looking at? What is a patient with metastatic urothelial carcinoma? What were they like? What are you telling the patient?
Right. So historically, what we had is cisplatin-based combination for cisplatin-eligible patients. Cisplatin-ineligible patients used to get gemcitabine carboplatin, and then came the maintenance avelumab data, patients who were responding or stable with gemcitabine platinum, which is about 70% of patients. They could go on to get avelumab. But the reality is when we did a real-world study looking at this, not many patients were getting to the maintenance avelumab portion for a number of reasons. So really a minority of patients was actually receiving the avelumab. And so this combination upfront with gemcitabine-cisplatin plus a PD-1 inhibitor takes care of that problem because everyone's getting the nivolumab, and the responses were early at a median of around 2 months, and the CRs were highly durable, and all the overall objective responses were also more durable than what we saw with the gemcis. So really, this is a step in the right direction. Remember that for the first time, we have a positive chemo IO trial. There have been negative trials, as you might remember, the gemcitabine with cisplatin or gemcitabine carboplatin when combined with pembro or atezolizumab, a couple of trials have been negative. So maybe cisplatin is more immunogenic and combines better with a PD-1 inhibitor.
Sure. And so this trial comes out last year, I think it was around October 2023. And it changes the game, right? So these patients now, they're getting a PD-1 inhibitor, which is obviously easier to administer rather than maintenance therapy. And they're doing what? So you said already. So 3 years. So what does that mean? What does 3 years in the world of metastatic urothelial carcinoma mean?
Right. That's a long time to be for the duration of CR. What we know is that these patients recur early and fast. So if you go in a complete remission longer and longer, the better the chances you're probably cured. I think we need to figure out how many of these patients are actually cured. Maybe we need a little bit longer follow-up. This trial had a fairly long median follow-up of close to 3 years, a median follow-up.
Which is fantastic for a
Yes.
bladder metastatic, right? In my
That's
understanding.
that's a long time.
Sure.
I think I'd like to see an even longer median follow-up to see what the tail of the curve really looks like. But it's a very nice tail to the curve with separation in the PFS and even survival long term.
And it's particularly important in a group like this to look at subgroups and see why certain people responded and how. So can you tell us about some of the things that were published and dispersed at this conference?
Yes. At this AUA conference, we looked at people who had responded. There was around approximately 57% of patients who responded, to look at whether there were any differences between that population and the overall intent to treat population. The bottom line is the demographics is similar. There was nothing really special about these responders. They had similar demographic and clinical factors, sites of metastasis. The toxicity profile was similar. One interesting fact is when we looked at the tumor regressions, the depth of tumor regression was more with GemCis-Nivo as opposed to GemCis. There were more patients who had more than 90% tumor regression. So it's not just the overall response and the CR. When you look at the 90% regressions, also it was better. So at the end of the day, what we really think we need to do is find a biomarker that predicts response and, more importantly, complete response, because that's where the money is. The complete responders are going so long that, and we're giving them a treatment-free interval.
Yep.
And with a finite duration of chemo as well as the nivolumab. So that, I think, is a key direction we want to go with this regimen.
And we know that there's going to be future conferences and future, obviously, we talked about a longer, duration of follow-up for these patients, but it's unbelievable. So thank you so much for your time, and we're looking forward to what comes in the following conferences.